Okay, welcome everybody to tonight's Q&A session on the kidney. I thought I would start with this slide, which is a bit surprising. What it shows is the number of patient deaths in the US every year in thousands. So you have to multiply each of these numbers by 1,000. And what you see is that patients who die of kidney failure exceed many cancers, including colorectal cancer. About 2.5 times as many patients die of kidney disease than breast cancer, and prostate cancer is even a greater fraction. The only cancer that exceeds kidney failure deaths is lung cancer. So this slide is surprising to a lot of people. Now, every year, about 100,000 new patients go on to dialysis. In the US currently, there's about 650,000 patients on dialysis, and every year about 100,000 of those people pass away, so that the number of patients starting and the number of patients that are dying is roughly the same. So the number stays around 650,000. It fluctuates, sometimes it increases, sometimes it decreases, but we're in a so-called steady state. It used to be increasing at a much greater rate, but because we're able to keep people alive to a greater extent, the number of deaths on dialysis has decreased. And in certain racial groups, there's a continual increase in the number of patients going on dialysis, but the total is around 100,000 a year. Now, for those of you that aren't familiar, the kidneys are located towards the back of your abdomen, not the front, and they each weigh about 1/3 of a pound. We have 2 kidneys, but we only need 1 kidney to survive. And in fact, as I'll show later, we only need about 10 to 15% of the total 2 kidneys in order to not be on dialysis. When your total kidney function gets down to about 10 or 15% or so, that's when you have to start thinking of what we call renal replacement therapy. And I'll talk about those therapies shortly. When one thinks of what the kidney is made out of, it's made out of what are called nephrons. And the nephrons have 2 components. There's a filtering component, which we call, as shown on the left, the glomerulus. This is one of the filters in the kidney. There's about 1 million of these in each kidney. And the filter is attached to a tubular structure that we call the kidney tubule or the nephron. The nephron really should include the filter, the glomerulus. The filter, or the glomerulus, filters blood. It prevents the components of blood from getting into the rest of the tubular structure. So it prevents red blood cells, white blood cells, and platelets that are floating around in your blood from getting into the rest of the tubule. What comes through here looks like a yellow plasma that sometimes when you get a cut, you see this yellow substance or liquid oozing out. That's what really comes through here. In the tubular part, there's no filtration. What occurs here is that different substances are either absorbed back into the blood, which is not shown here, or substances from the blood are transferred into the tubule, so that at the end, you have a solution that contains the chemistry that we call urine. Now, in general, what the kidney does is it senses the changes in the chemistry of your blood that occur when you eat. Every time you eat, you change the chemistry of many, many, many substances in the blood. And the kidney recognizes the change such that what it excretes in a 24-hour period returns the blood chemistry back to normal, despite the fact that you eat. So some of the things the kidney is monitoring and making sure that what comes out in the urine is appropriate is potassium. It's important that potassium comes out of the urine appropriately, because if your blood potassium increases to too great an extent, it can affect the electrical part of your heart, and you get what's called cardiac arrhythmias, where your heart doesn't beat normally. Potassium is found in bananas, fruits, and meats and fish. And so just from your normal diet, you're always putting potassium into your bloodstream, and it has to be gotten rid of. If it isn't gotten rid of because the kidney isn't working well, your blood potassium will increase, and that's when you can get into trouble with your heart function. The kidney also gets rid of what's called nitrogen. Nitrogen is in amino acids, and amino acids are in proteins, and proteins are in meat and fish, milk, eggs. And so the kidney has to get rid of the nitrogen also. And it does so in the form of something called your BUN, or some people call it BUN, but it really stands for blood urea nitrogen. And it's the compound that all the nitrogen from the food you eat is attached to, and the kidney gets rid of the BUN. The kidney also gets rid of salt and water that you ingest. And if it doesn't get rid of the salt and water appropriately, your blood pressure will go up. And right now, 45% of Americans, approximately 45% of Americans over age 18 or older, have a high blood pressure. And the range of having a high blood pressure has been decreased in the last 4 years, such that if your pressure is over 130 over 80, you're considered to have a high blood pressure. Remember, there's always two pressures. The top number is the pressure just when your heart beats. So when your heart contracts, the pressure goes up to, let's say, 130. But after the beat, the pressure doesn't go to zero. You still have a pressure. It's just lower. And anything over 80 is considered too elevated. So if the pressure is high, and as it's shown here, a large percentage of people have high blood pressure, most of whom don't know it, because most people don't measure their pressure. Having a high blood pressure doesn't make you feel any different in most cases. So most people don't even know they have it. It's a silent problem, and because it's silent, you're not aware of the problems that it can cause. And it has effects on the heart, it has effects on your brain, sometimes it can involve the kidney. And so it's something that, because it affects multiple organs, it's a mistake not to take it seriously and keep the number low. And it's also very easy for doctors to keep it within the normal range. There's many pills, and they have many different mechanisms and targets of action. And it's highly unusual that we're not able to lower the blood pressure into the normal range. Now, the other thing to realize is that the blood pressure is not constant. It changes throughout the day. So it depends when you measure it. Some people have a high blood pressure in the morning, and it's normal in the afternoon and at night and in the middle of the night. Other people develop a high blood pressure at 11 o'clock at night, and it's normal the rest of the day. So it's very important when you measure your blood pressure to measure it at least 3 times a day to get a feeling of the pattern. And everyone has a pattern, even if it's in the normal range. Your blood pressure tends to go down in the evening and tends to start coming up again at 4 in the morning. People with high blood pressure can have a different pattern. So it's really important to determine what your own pattern is. And that also affects how we treat it. So for someone who has a high blood pressure in the morning, we don't want to give them a pill in the morning, because then it won't do anything. The pill takes 2 or 3 hours to start working. It's already too late. So if they have a high blood pressure in the morning, we'll give them a pill before they go to bed, so that that pill will lower the pressure in the morning when we want. Whereas if the patient's blood pressure is high in the afternoon, we'll give them a pill in the morning to tackle the pressure in the afternoon that's high. If it's high in the afternoon and in the morning, we'll give them 2 pills a day, 1 in the morning and 1 in the evening. So it depends when the pressure is high. And it's also important to realize that blood pressure is often high in the doctor's office because of something called white coat syndrome. People are nervous and anxious when they go to a doctor, and their pressure always goes up. So we tend not to treat based on what we get in the office. We like people to get their own blood pressure cuff and then measure it at home, record those pressures either in an Excel spreadsheet or in a book, and then bring those pressures into the office when they're seen. And based on those numbers, we'll decide whether, first of all, the pressure is abnormal, and if it is, what to do about it therapeutically. The kidney is also important because it makes a hormone called erythropoietin that causes the bone marrow to make blood, to make the red cells in your blood. And people who have kidney disease often don't make this hormone and they become anemic. So when you don't have enough red cells, it's called anemia. And the kidney is responsible for making sure you're not anemic. And people who are on dialysis often have kidneys that not only don't function and filter, they also don't make this hormone. So we have to give them this hormone artificially. And it's usually given as a small little needle under the skin or intravenously, depending on whether they're on hemodialysis or another form of dialysis called peritoneal dialysis. The kidney is also important for maintaining your skeletal calcium levels normal because it makes a hormone called 125 vitamin D. Now you might have, I'm sure you've heard of vitamin D, but the vitamin D you buy at the pharmacy is not the active form. The kidney takes that form and turns it into what's called 125 vitamin D, and that's the form of vitamin D that works on your bones. So if you don't have normal functioning kidneys, you don't make 125 vitamin D normally, and that's a problem because your skeleton can lose its calcium and become very fragile, and you can get fractures and all sorts of other problems with the skeleton. So patients with kidney failure, we have to often give them vitamin D and sometimes 125, very high doses of vitamin D, much higher than you would normally take, or 125 vitamin D. So people that have kidney disease tend to, if it's very severe, present to the doctor with a number of different findings. Because it affects your salt and water excretion, if they can't excrete the salt and water normally, the salt and water will build up in their body, and because of gravity, it tends to cause swelling of the feet, especially if you're standing all day. That tells us that there's a problem with salt or water excretion because they tend to go together, and that's one of the signs of kidney disease. Another symptom patients with severe kidney disease have is they lose their appetite and they can feel nauseous. Oftentimes it's misdiagnosed as some problem in the stomach or the GI tract, but it's not. It's the kidney that causes the nausea and the lack of appetite. It's not well understood why the kidney does that, but that's one of the important symptoms. Again, because the kidney can't get rid of salt and water, not only can you get swelling in your feet, you can also have a high blood pressure. And the kidney also, because it controls all these electrolytes, sodium, which is Na, potassium, which is K, calcium is Ca, magnesium is Mg, phosphorus is P, bicarbonate is HCO3. These are the electrolytes that are part of the chemistry of your blood. These blood tests can be abnormal in kidney disease, and we have to treat the patient either with pills, or we have to, if kidney disease is very severe, dialyze the patient to get these these electrolytes back to normal. As I said, because the kidney makes erythropoietin, the hormone that controls how much red blood cells you have, if you don't have enough erythropoietin, you can become anemic. For some reason, patients also can have symptoms of depression, but they can also be confused, the symptoms they have with being depressed. So you have to have very accurate psychological tests. And often the doctors who aren't familiar with depression misdiagnose patients with kidney disease as having depression. But when they have an objective test of their symptoms, it's found they're not depressed. Their symptoms can mask, or not mask, but can simulate depression. So it's very important that doctors distinguish true depression from symptoms that look like depression. They can also have sleep disturbances. They wake up a lot in the middle of the night. They don't sleep normally. Sometimes they have sleep-night reversal, where they sleep during the day instead of sleeping at night. And then another interesting symptom is the fact that their taste becomes abnormal. And it's not that they get strange taste, it just, everything seems less intense. So they'll have a nice spicy meal and they really won't taste very much. And it's a big problem, because not only can they lose their appetite, but now the food doesn't really taste very interesting to them. And so because of these two things, they can stop eating as much, and then they can lose weight, and lose their muscle mass, and this kind of thing. So it's very important in patients with kidney disease to make sure they eat properly, even though they don't want to eat a lot of them. And one of the few things we do is just to put a ton of spice on the food to make it more interesting for them. There are some new pills that are coming out now for some of the patients that seem to make their taste a little better, but those are still being studied and aren't readily available. Another complaint they have, which is not listed here, is itching. Patients on dialysis oftentimes get itching, and the itching can be at night, which is another reason they don't sleep as well. There's a new drug that just came out for hemodialysis patients, but it's intravenously given, which is fine for them because they're dialyzed through their blood, so it's easy for the nurse to give them the compound in their bloodstream. But for patients that are on peritoneal dialysis, where they don't have an intravenous, they can't get this new pill yet for the itching because it's not given in pill form. It has to be given intravenously. So what are the tests for kidney disease? One of the important tests is a test called creatinine. And it's a blood test, and it's a very simple test. And if the creatinine is 1, your kidney function is normal. When we say kidney function, we're not talking about your anemia. We're not talking about many of the things we talked about. You're talking about the filtration capability of the glomeruli, those filtering units here. 4 of them are shown here. Remember, you have 1 million or so in each kidney. So if the number is around 1, your filters are normal. If the number jumps to 2, the way you can think of it is you have half the number of filters. If the number jumps to 4, you have 1/4 of the filters. You get into trouble needing dialysis or a kidney transplant if you get to about 1/10, 15% to 10% of your normal filtering ability. In which case your creatinine will be, 8, 7, 8, 9, in that range. The other tests we do are on the urine. We look to see whether people have what's called protein in the urine, because normally the urine should have very, very, very little protein. It doesn't get through the filters. But if the filters are damaged, there's going to be protein in the urine. And there's many types of protein, but the one that typically comes out is called albumin. Albumin is the protein that's in egg white. Egg white is basically albumin. So when you think of an egg, not the yolk, the egg white, you're basically eating albumin. And we normally have albumin also in our blood, and that albumin does not get out in the urine because the filters will not let it into the urine. The filter keeps it in the bloodstream. But if you have damaged filters, kidney filters, for whatever reason, the doctor will find it in the urine. And the quick way in the office to test for it is what's called a dipstick, this strip that has different squares on it, whose color changes depending on how much protein there is. We can also send the urine off to get an actual measurement of how much protein is in the urine. So it's something the doctor assesses. One thing that we find phenomenologically is when there's a lot of protein in the urine, it's foamy. The other thing that's looked for by the nephrologist is whether there's blood in the urine, because normally there's virtually no blood in normal urine. But you can see here, as there's more and more blood, it gets redder and redder, as one would expect. Even in the urine on the right, where it looks like there's no blood, there still can be blood under the microscope. When we look at the urine, we look for red blood cells. So the urine is looked at grossly, and we call that gross hematuria if there's a blood that's seen with your eye. If we can only see it under the microscope, we call that microscopic hematuria. Hematuria, heme means blood, uria is urine. So microscopic hematuria. So we do both. Now, the most common cause for red urine is not blood. It's because people ate beets. And we see that intermittently, where someone is very anxious or afraid because they think they have blood in the urine, but all it was is they had beets the night before, and the color from the beet is gets through the filters and comes out in the urine. So that's a transient redness to the urine. It goes away. The other thing we look for are bacteria. Women who are sexually active often get urinary tract infections, and it can occur spontaneously. And so what's shown here on the right is what we see under the microscope. All these little black things here are bacteria, and you should never see that. I mean, none of these should be there. And we also will take the urine and grow it on an agar plate, and these colonies here are colonies of bacteria growing, which again, you should never see. This plate should be smooth and red with nothing on it. All these things here are bacteria growing. And from this, we can tell the type of bacteria, and we can also tell what type of antibiotic the organism is responsive to so that we can treat the patient appropriately. Now, what are some of the diseases that affect the kidney? The most common in the world is diabetes. This cartoon here said God sent Adam and Eve out of the garden because of the apple. Apples have carbs, and carbs are evil. That suggests that it's the sugar going up that affects the kidney, and it's much more complicated than that. So the take-home message is that diabetes is not just a sugar problem. It actually has another problem in that it destroys blood vessels, and this can occur throughout the body. This is a normal artery, and this is a diabetic artery. You can see the inside wall here has this yellow stuff on it, and there's blood clot on it. And you can imagine that if this gets worse and worse and worse, the flow to the kidney and other organs, if it affects other arteries like your brain or your heart, is going to become diminished over time, leading to severe organ functional abnormalities. So if this gets very severe in the heart, you can have a heart attack. If it gets very severe in your brain, you can have a stroke. And in the kidney, it leads to decreased flow to the kidney and therefore decreased filtration function and overall function. Now, the second thing the diabetes does to the kidney is it affects the filtering units. This is just one filtering unit, one glomerulus that's cut in sections, so it's two-dimensional, not three-dimensional. And this is what it would normally look like. A diabetic glomerulus looks like this. It's filled with all this stuff in it. And you can see just from looking at it, it's not going to filter normally. And if this gets very severe, the patients can stop filtering and they'll need to go on dialysis when the filtering ability gets down to about 10%. So in a typical diabetic, if they're going to have abnormalities in the kidney, it takes about 18 years to go from this to this. So it's a slow progression over time. Now, not all diabetics will have a kidney problem. Only a certain percentage of them do. There's two types of diabetes, type 1 and type 2. Type 1 diabetes is when your pancreas loses the ability to make insulin. 40% of those patients will have kidney involvement. The second type of diabetes, which is much, much more common, is diabetes due to obesity or being overweight. When you become overweight, it's not that your pancreas can't make insulin normally, it's the insulin doesn't work well on your cells. So you have insulin, it's just not working properly. And that's by far the most common cause of diabetes. And sadly, it's reversible. If you lose the weight and bring your weight down to what your ideal body weight should be, the diabetes goes away. But sadly, the patients we typically have in a dialysis unit and in a nephrologist's office are diabetics who are overweight. And eventually, if it's severe enough, they can destroy their blood vessels and go on dialysis, destroy their glomeruli. Only 20%, though, of the so-called type 2 or obese diabetics get kidney involvement. So even though 40% of the type 1s get kidney involvement, type 1 is much less common. And that's why even though 20% of the type 2s have kidney disease, it's much more likely to have a type 2 person in your office or the dialysis unit who has kidney disease. Another form of kidney disease that's very common worldwide, again, something that affects the filters, is called IgA nephropathy. And you can see this filter here compared to this one, where you have these nice capillaries that are wide open and filtering. Here, you can't even see anything wide open. It's like the whole filter is filled up with all these things. These are actually too many cells. And these patients have what's called IgA. It's an antibody that attaches to the filter that you see here. You should never see this in a normal glomerulus. And they present with blood in the urine because the filter not only filters less, but it lets red blood cells through. This is very common in Asia. And if you have a patient with this type of disease and someone asks you what is causing the problem, if you say IgA nephropathy, you're most likely going to be right. We don't have a treatment for this yet. There's some investigational drugs being tested, but nothing definitive. Another problem people can have is not a problem with the filtering units and not a problem with their kidney function. They don't need to be on dialysis. It's that their kidneys are making stones, which you should never see. And these stones can form in the inside of the kidney, get bigger and bigger. And if they're below a certain size, they will fit through the tube coming out of the kidney called the ureter, and they will get into your bladder and they will come out into the toilet. But if the stone is too big, it cannot get out. There's many different types of stones depending on what they're made out of. The most common stone is made out of calcium oxalate. It's called a calcium oxalate stone. Having a kidney stone pass is worse than being in labor. It's the most severe pain that a human being can experience. And it goes from your back, your lower back, all the way into your groin as the stone travels down. And people have to be on morphine. It's so severe. There are other diseases. This is a genetic disease, probably the most common genetic disease that causes people to be on dialysis. It's called polycystic kidney disease. And it results in the kidney having these big blebs, almost look like grapes. Instead of being a nice smooth outline, the kidney looks like this. It's not often present in the first 20 or 30 years of your life. These blebs develop often in your late 30s, 40s, and 50s. And here's another example. Compare it to a football, which could be a normal kidney with a smooth outline. The kidney gets larger. These things can bleed. Every time they bleed, they can cause some back pain, or you'll see blood in the urine. Because the architecture of the kidney is becoming very abnormal, the filtration function of the kidney can be abnormal, such that you may even end up on dialysis. It can lead to high blood pressure because you can't get rid of the salt and water. It can lead to anemia, all the things we mentioned. So about 10% of people with end-stage renal disease, it's due to polycystic kidney disease. We have some newer treatments that are being studied. They help a little bit, but we have nothing definitive that can make it go away. Another entity that affects the kidney is called lupus. It tends to occur in young women. This is a normal glomerulus. All the capillaries are wide open. They're able to filter the blood nicely. This is a glomerulus of a patient with lupus. You can see tons of, these are cells. The glomerulus is filled with inflammatory cells. It's a real inflammation, and you can see that the filtering ability of the glomerulus is going to be severely impacted. So again, all the consequences of that: salt and water not coming out of the kidney, potassium going up, feet getting swollen. Again, it can affect the hormonal erythropoietin production of the kidney, so they can become anemic. These patients tend to not only have inflammation of the kidney, but in many organs. So this young girl has inflammation under her skin and in the cheeks. This is very commonly seen. It's called a malar rash. If you see this, don't just think someone was out in the sun, especially if they tell you they weren't in the sun. You have to think of lupus. It can affect all organs in the body, the heart, the brain, any organ can get inflamed. This is something else the kidney can have, and this is kidney cancer. This is a CAT scan. So here's a cancer forming. Usually it forms from the tubule part. It never really forms from the filtering units. So some of the cells in some of the tubules became abnormal and started to divide too much and formed what we call a mass. And you can see here, this is a CAT scan. This is what the kidney looks like. This is a normal kidney on this side. But you can see this kidney looks really abnormal. It's got this huge thing coming out of it. This is the normal kidney over here, but you should never see something like this. So just thinking of it quantitatively, when we get the kidney function, we have the blood test that I said called the creatinine, and that's turned into something else called either GFR or eGFR. The E stands for estimated, because we're not measuring the GFR, we're estimating it from the creatinine. And based on this GFR assessment, we stage the kidney. They're called CKD stages. CKD stands for chronic kidney disease stages. If the answer is above 90, if it's 100, you don't have any CKD. If it's around 90, then you have very slight kidney involvement. That's stage 1. And we have stage 2, stage 3, stage 4. And as I mentioned, if your kidney GFR or eGFR gets down to about 15% or less, then and it's predictably not going to go back, and it's going to stay there chronically, then you really need to start thinking of dialysis or a kidney transplant. So what we do is we track the patients over time, and we watch the decline in their kidney function to try to predict when they're going to get down to 15. Now, some people, will get to between 30 to 59% of their function, and they won't decline anymore. They'll just stay there, and that's great. They never need to go on dialysis. Other patients will stop decreasing at 15 to 29. And again, most of those don't need to go on dialysis. But if you get down to this range, you're really knocking on the door of kidney replacement therapy. And even earlier than that, by this time, we'll start talking to patients about what their options are. Do they want hemodialysis? Do they want peritoneal dialysis? We discuss what they are and the pros and cons. We talk about kidney transplantation also. So this is hemodialysis, invented during World War II in 1942 in Holland. And this is how most patients are treated in the United States now. Of the 650,000 we talked about, they come in 3 times a week to a clinic, usually for 3.5 hours at a time. And then the rest of the week, they're not being treated. Now, this doesn't replace the normal kidney function. It provides them the minimum amount of treatment they need to stay alive. Ideally, it would be much more than that. And there are some dialysis units and research programs where people are dialyzed every day, and there's variations of that. Some people come in the evening and are dialyzed all night. They stay at the dialysis unit. Other programs have, and including ours, have what's called home hemodialysis, where people have a machine at home and they pay for a technician to come in and hook them up, dialyze them, or they put the needles in themselves. They know how the machine works. They dialyze themselves. So it really depends on the motivation of the patient, their education, their desire to look after themselves without any help. But it allows them to be free and not have to go to a clinic 3 times a week. They just have the machine in their home. They can do it every day if they want. They're usually very highly motivated patients. And in the United States, maybe 3 to 5% of all the patients do home hemodialysis. The US government, and because of that, the insurance companies and the private companies like DaVita and Fresenius that are providing most of the dialysis in the United States would like to have a much higher percentage of home hemo patients. I think it's the patients themselves. Most people don't want to do this at home by themselves. And also, the dialysis population tends to be a population of patients that are getting older and older all the time. Most patients in our unit are now in their 70s, and it keeps going up and up slowly over time. And these patients tend not to want to do it at home either, because they just feel safer if there's someone else helping them. They might have eyesight problems. They might not want to get into the technology, learn how to use the machine. There's many sociological reasons why it just hasn't gotten above 4 or 5% in the US, and it probably never will. Another form of dialysis that came to the fore in the late 70s is called peritoneal dialysis. there's no blood involved. There's no needles involved. They have a catheter that's put inside what's called the peritoneal cavity. And they walk around with this catheter all day. At night, they hook themselves up to these solutions that come to the house or apartment. And while they're sleeping, the machine takes the solution, puts it into their abdomen, and after 2 hours drains the solution. The machine then takes it, it only shows here 2 solutions, but what happens is this happens 5 times throughout the night. Every 2 hours, a new fresh solution is put in, and the solution that has the waste and the chemicals in it that come into it via dialysis technique are taken out of the abdomen into the waste bag, so that after the night is over, they have 5 bags that are waste bags. Sometimes there's one bigger bag. It depends on what they've ordered. But the bottom line is there's solutions that go in and come out. And once they come out, they're tossed. And fresh solutions go in every single night, so that this procedure differs in that it's done daily. It's done while the patient's sleeping, and there's no blood involved. So it's a much more gentle procedure because it takes all night to do, and it's done more slowly at night than hemodialysis, which is a much more aggressive technique. This is what the US government would like most patients to be on. Right now, what we're facing are solution shortages because of the supply chain issues. We're also facing solution problems with the hemodialysis solutions also. But in general, this is staying pretty flat too in the United States. The US government would like to get up to 40 or 50% of all the patients on peritoneal dialysis. It's still roughly in the 20s right now. And every nephrologist would go on this technique if they were asked. They would all do peritoneal dialysis, not hemodialysis. And then lastly, which everyone knows, there's kidney transplantation. People often ask what happens to the diseased kidneys. Well, they're left in because they still may have some function. Even if it's 2-3% of normal, it's still some function. So to remove them isn't as good for the patients, and there's no need. And also, they may be making erythropoietin to help with the creation of blood, and they may be making 125 vitamin D. So why remove the source of those hormones? Even if it's less than normal, it's still better than nothing. So the transplanted kidney is put here, and often patients will have 4 or 5% of their so-called native kidney function, and the rest is coming from the transplant. If these aren't functioning at all, then it's all coming from the transplant. These patients have to go on immunosuppressive agents. These drugs are not benign that they go on. They have side effects. One of the things we always look for is cancers that are appearing, because people don't get cancer because your immunity is suppressing the cancer cells. But when we suppress the immunity with these drugs that prevent the rejection, oftentimes skin cancers will come out, especially if people have been in the sun, and other cancers. So we're always looking for that. And that's why if you've had cancer, part of the workup for a kidney transplant is to send you to an oncologist, because what we don't want, especially if the cancer is now gone away, we don't want to bring it back by the drugs that we're giving for the kidney transplant. Sometimes the oncologist will say, it's too early. We have to wait another year or 2 to make sure the patient is truly cancer-free before we'll take the risk of putting them on these immunosuppressive drugs. So I think I'll stop there. And what I try to do is just give you a sort of a high-level overview of kidney disease, its prevalence, and some of the diseases that we see and how we treat them. And I'd be glad to take any questions anyone might have.